Well, good afternoon, everybody, and welcome to the University of South Dakota Sanford School of Medicine, Department of Pediatrics Grand Rounds. Today is exciting because we resume our Grand Rounds. We did have that hiatus in June, and who best to start this month than Rapid City's pediatrics allergist, Dr. Haley Anderson. Dr. Haley Anderson is a clinical assistant professor at the University of South Dakota Sanford School of Medicine and is a solo practitioner in allergy immunology in a multi-specialty clinic in Rapid City, where she also serves as a consultant for Monument Health. Dr. Anderson achieved her Bachelor of Arts degree in biology at the University of St. Catherine in St. Paul, Minnesota. And in 2011, she received her medical degree at the University of South Dakota Sanford School of Medicine, where she was elected into the Gold Humanism Society. She then did a residency and chief residency in general pediatrics at the University of Wisconsin Hospitals and Clinics in Madison, Wisconsin. And after finishing her chief residency, Dr. Anderson stayed at Wisconsin Hospitals and Clinics, pursuing a fellowship in allergy and immunology with cross-training in both pediatric and adult allergy and immunology. Dr. Anderson has co-authored several peer-reviewed articles, 5 as first author, and she has given several poster presentations at national meetings. In her CV, Dr. Anderson states she enjoys spending time with her family, outdoor activities, soccer, and scrapbooking. She is a true South Dakotan. So please welcome Dr. Anderson, who will tackle that difficult subject of the nuts and bolts of food allergy. Thank you, Dr. Anderson, and welcome.
No problem. Thanks for having me. Can you hear me okay, Dr. Zeno?
Yep, you're doing
okay.
Fine. Great.
Sounds good. So thanks for the kind introduction, and I have a fairly ambitious talk kind of lined up for today, so we'll just kind of get going, and I'm sure people kind of jump on. So obviously this, doing a talk over virtually doesn't allow for as much interaction, but certainly if you have any questions, feel free to unmute yourself and ask a question. I'll do my best to address those as we go along. So I don't have any disclosures. I do have 3 disclaimers. These are my 3 children who apparently would make very, very beautiful Pixar movie characters. But that littlest one on the bottom is 4 months old, and she still likes to visit me in the middle of the night. So I've kind of giving myself a few ICD-10 diagnoses of being a little bit sleep deprived. So I hope that I don't have too many word finding difficulties and I'm not too distractible. My other disclaimer is that I am in clinic. I'm over on the west end of the state, and I have allergy shot patients who are here. So I've told them all that they need to behave, but obviously if something happens, hopefully they'll grab me, but hopefully that won't happen. So I do have a fairly ambitious talk because food allergy is a pretty lengthy subject, and really we're just going to scratch the surface of that today. I really kind of designed my talk with the audience of the pediatric residents in mind, and those specifically who are thinking about going into primary care, because I think hopefully that will capture the most relevance for all of you. So why do we care? And I think that this is fairly obvious, but food allergy is really increasing. And there's quite a bit of studies that kind of show us this in different ways. This graph kind of shows since the year 2000, we've basically doubled. I added one more bar graph, I think for 2016, there, the actual percentage of US children with food allergies was at 6.2%. I think it's fair to estimate that at this time, we're probably in the 6 to 8.8% range of children in the United States who live with food allergy. This is just another way to kind of look at those same statistics. So approximately 1 in 13 children, or roughly 2 in every single classroom, are living with food allergy. And this incidence is really, and prevalence has really increased. And, why that is a little bit beyond the scope of what I'll talk about today. It's pretty multifactorial and we don't really understand it very well, but it's certainly increasing beyond what we would expect with like normal evolutionary pressures. So probably some role of the hygiene hypothesis, we're a little bit too clean. Gut microbiome, antibiotic usage, processed foods, a lot of different, probably increased testing and just recognizing it more. All those factors are probably playing a role in why we have so much more food allergy these days. But certainly, we know when I think about my childhood days and in school, I can't remember a single classmate or friend who had a food allergy. And now with my children in school, it's there and it's present. And as pediatricians, I think we need to be pretty comfortable with it, or at least have some understanding of how to take appropriate histories in this regard. Most children have one food allergy, but at least 30% of children with food allergies are allergic to more than one food group, so making their life kind of uniquely challenging. Obviously not going to talk about adults just given our audience today. I just bring this slide up to mention that I think the public perception of food allergy is different than what the reality is. So many people, especially adults, will tell you I have a food allergy. In fact, 20 to 25%, if they're polled, will say I have a food allergy. In reality, in adults, probably only about 2 to 5% truly do. And in the kids, again, it's at 6 to 8%. So I'm going to give a few cases just to kind of hopefully frame our thinking around some of the different topics here. So this, I think, is a case that certainly could walk into your pediatric clinic. So Timmy is a 3-year-old male. He's brought in by his mother to clinic, and she is concerned that he may have developed a food allergy. A couple of weeks ago, he broke out in a rash on his face. Mom describes it as kind of red raised welts. They tended to move pretty quickly to involve his chest, his neck, and his back. She also noticed that his lips and his eyes were becoming a little bit puffy. She gave him a dose of Benadryl and put him in the bathtub. While he was in the bathtub, he vomited once. He was just kind of irritable and not himself, but over the course of about 15 to 20 minutes, he started to calm down. The rash stopped spreading and kind of started to subside. He never had any breathing difficulties, was never drooling, coughing, anything like that. He only vomited the one time. Mom did not take him into an urgent care and emergency room. He fell asleep. When he woke up from his nap, his rash was largely gone, but he still had some residual puffiness. So this obviously has Mom shaken up a little bit. She's trying to figure out what it is that he's allergic to. So this is the reaction, Mom states, happened around 3:00 p.m. in the afternoon. He was in his normal state of health leading up to that time. He didn't have any symptoms of a viral illness. There's no viruses going around the family. He'd been at home all day, no new or unique exposures or travel history. Just briefly, his 24-hour diet history, pretty normal diet according to the mom. They had fish sticks last night. This morning he had eggs, toast, and orange juice. He eats that a few times, definitely on the weekends. For his morning snack, he had apples dipped in peanut butter. He eats peanut butter jelly sandwiches pretty regularly. For lunch, he had a hot dog and some cow's milk. He eats dairy without any issues. For his afternoon snack around 2:30, he had carrots and celery dipped in hummus. He's had hummus before. And then after the reaction had all resolved, they had spaghetti with pesto sauce. So I think that's a helpful framework to think about our talking a little bit about food allergy. So what is true food allergy? This is really important to me. And it sounds a little bit maybe like semantics, but I think it's really important to actually truly define what a food allergy is versus other food allergic reactions. And for me, it's important because it helps me know how my testing is going to be helpful. So a true food allergy is an IgE mediated reaction. It's also known as an immediate hypersensitivity reaction. This is the type of reaction that has the potential to go on and cause anaphylaxis. And it's really an immunologic reaction. So basically, your body's immune system is recognizing a food protein as being dangerous. And every time your body's exposed to that food protein, it elicits this reaction that results in mast cell degranulation and all the symptoms of an allergic reaction. It can happen with very minute amounts of food. It's generally very reproducible and it's not picky. So it's not going to happen it's not like, a kid could have peanut butter one time and eat it again and not have issues and then have another time. It generally is every single time they're exposed to it. Once they're allergic, they tend to have reactions to it. Usually it's actually not on the first exposure, which I think in real life, sometimes we think it does happen on first exposure, but you need some form of a sensitizing dose. So a lot of times that first dose or the first time they eat it is actually the sensitizing dose. And then subsequent reactions are when you actually see the reactions. Now we know that, especially in kids who have a broken skin barrier with eczema and that sort of thing, they can be sensitized through their skin. And maybe there's some other sensitizing routes perhaps as well that we don't understand very well, but I will say that certainly sometimes kids can have reactions on their first exposure. Obviously, these reactions can be severe and have the potential to be life-threatening. And we call it an immediate hypersensitivity because it happens fast. It happens within minutes to hours of the ingestion of the food. And so with very rare exception, these reactions are fairly immediate, and that's where your history can be very important. So I think it's helpful to kind of break down the different types of food reactions into these different classification systems. So IgE mediated food allergy is what we'll obviously spend a lot of time talking about today. And this is, the anaphylaxis, the urticaria, the angioedema. There is something called oral allergy syndrome or food pollen syndrome is another word for it, which is IgE mediated. This is a process that you're not going to see as much in your young children, but certainly may see it in teenage patients. And it actually represents a cross-reactivity to being allergic to pollen. And so there's fruits and usually it's fresh fruits and vegetables, and there's proteins in those that look like the pollen protein to the body. And so then when they ingest those in the oropharynx, the IgE receptors bind and you get some oral pruritus and, throat discomfort, sometimes some abdominal upset. And then if the foods are extensively heated or baked, those foods are tolerated. So, if it's not an IgE reaction to the banana, for example, but it is a IgE reaction to the ragweed, and the fresh banana is cross-reacting with that ragweed pollen. And usually in those kids, they have trouble with fresh banana, but they can eat banana bread and not have any symptoms. So won't talk about that any further, but I do think it's something to be aware of. Then we have this category of kind of mixed IgE and other mechanisms, non-IgE mediated. And this is where kind of our eosinophilic GI diseases come in. This is also where atopic dermatitis or eczema kind of comes in, where there's probably some role of IgE mediated disease, including food allergy, but there's other mechanisms at play as well. And then we have that last category, which is our non-IgE mediated or our cell mediated reactions. And so this is like your FPIES, your food protein induced enterocolitis syndrome, the FIAP, the food induced allergic proctocolitis, which used to be known as the milk soy protein intolerance, celiac disease and the skin manifestations of that. Those are not IgE mediated. So you're not going to expect that your allergy testing, for example, is going to be able to pick up on those processes. Unfortunately, all of those could be a topic of their own, and we could talk about those, but we're going to really kind of focus on the IgE mediated allergy today. Just briefly about the biology of allergic reactions, our immune system obviously makes several different types of antibodies. IgM, IgG, and IgA are important for fighting off, for immune memory and fighting off microbial infections. IgE is what we consider the allergy antibody, and they have specific epitope receptors for different allergens. And so this little cartoon just shows a depiction of a mast cell and what happens. So you can see in this picture, the little yellow Y-shaped antibodies are your IgE antibody, and they have, they're specific to a particular antigen. And if someone ingests that food antigen, it comes in and it cross-links those different IgE receptors. What that does is it elicits a cascade of events in the cell, and basically causes some degranulation of the mast cell, and that releases various pro-inflammatory vasoactive chemicals into the surrounding bloodstream. So those are things like histamine, tryptase, leukotrienes, platelet activating factor, etc. And then those chemicals are what cause the various organ system reactions. Mast cells, I explain to my patients, are kind of like the allergy factories in our body. We all have them. They line our skin, they're in our respiratory tract, they're in our GI tract. And again, they're what are responsible. Their activation is what's responsible for allergic reactions. Basophils also play a role in this, but the mast cells seem to be the major player. This is just another kind of cartoon about what happens, what the organ system effects are of mast cell degranulation. So in the GI tract, you're getting increased fluid secretion and peristalsis, which leads to trying to get things out, basically. So, nausea, vomiting, abdominal cramping, and diarrhea. In the airways, it leads to bronchoconstriction and increased mucus secretion. So in the lower respiratory tract, you're going to be getting your asthma-like symptoms of wheezing, coughing, shortness of breath. Upper airways, you can have some laryngeal edema, rhinorrhea, sneezing, nasal congestion, that sort of thing. With the effect on blood vessels, there's an increased blood flow and increased permeability. So in the skin, that leads to edema and, the wheals and flares that you get with the urticaria and the angioedema. And certainly some increased vessel permeability can lead to hypotension and that sort of thing. So what are you going to see? Far and away, the most common reaction that you're going to see with a food reaction or with a food allergy is urticaria and angioedema, so hives and swelling. Angioedema is essentially just a deeper tissue hive, except it's happening usually in a body part where there's not a lot of room for swelling, so it's pretty dramatic. Just for the classification, we think about the different organ systems that are involved. We all consider hives and mucous membranes as one organ system. So again, if someone's having angioedema of their lips, that's still considered kind of a cutaneous manifestation of an allergic reaction. We talked about these already, but obviously the other signs and symptoms are the GI symptoms, the laryngeal swelling, which can cause, difficulty swallowing secretions, kind of stridulent breathing, hoarseness of the voice. This is a very anxiety producing symptom for people, understandably. You can hear wheezing on exam. Usually they're not hypoxic, but obviously that can progress. And then, the worst case scenario is you get ultimately hypotension and potentially cardiovascular collapse. People can get real dizzy. They can syncopize on you. If later we'll tell you that they feel like they're going to die. There's an impending sense of doom for these people if their reaction goes untreated. So again, anaphylaxis is our most serious type of allergic reaction. It is potentially fatal. It requires basically 2 or more organ systems be involved in the reaction. Typically, this is skin plus another organ system. So hives plus vomiting, hives and angioedema plus wheezing. That is what categories as anaphylaxis. If they're having just hypotension and nothing else, but they have had a known allergic exposure like a food or a bee sting, that is also a definition of anaphylaxis. So I'm going to quickly move along to kind of the most common food allergens, and we'll kind of breeze through these pretty quickly. Earlier, we talked a little bit about the prevalence of food allergy, and this graph or this table, I guess, breaks it down more based on what the food type is. So cow's milk, egg, and peanut are the most common food allergens in kids. Cow's milk is the most common. That changes with time. So these things, people can outgrow and lose their food allergies. And so we definitely see that. And then interestingly, shellfish allergy is something that usually comes on later in life. So a little bit more about the natural history. In the literature, it says about 80% of milk, soy, egg, and wheat allergy resolved by teenage years. I think it might actually be higher than that, at least in my anecdotal clinical experience. And this is reflected by, declining levels of specific IgE. So if those are going lower, their skin test is getting smaller, it's predictive that things are outgrowing. Also, with milk and eggs specifically, a lot of times when those foods are extensively heated, it changes the epitopes and the conformation of where things bind, and they become less allergenic. So many people and kids who are milk and egg allergic can tolerate these foods in extensively heated form. And that's usually a good prognostic sign for their eventual outgrowth of the milk and the egg allergy. In my experience, most kids, not all obviously, but most kids will tend to outgrow their milk and egg allergy by the time they're school age. Allergy to nuts, unfortunately, are a little bit more preserved. There's a lower chance of outgrowing these, probably around 10%. And then seafood allergy, as I mentioned, usually starts later on, usually in late teens, 20s to 30s, and that persists throughout adulthood. It's not impossible to have a shellfish allergy in a young child, but it's very uncommon. And then these patients have a high likelihood of having other allergic disease. It's kind of that atopic march that we're aware of. So they can, have other food allergy. They certainly have a high risk of having environmental allergies and persistent wheezing. So milk is the most common allergen. The major allergens are the beta lactoglobulin and alpha lactalbumin are the whey proteins in cow's milk. And then there's also the casein fraction. So it's really the casein and the whey that people are allergic to. This is relevant because the whey proteins tend to break down a little bit more extensively when they're heated, whereas the casein fraction are more heat resistant. So sometimes if I'm worried about whether a kid will tolerate baked milk or not, I will get kind of a fractionated milk allergen to kind of help me decide if I feel like they're going to be safe for a milk challenge. Now, The other thing is I think this comes up a lot of times in your teenagers who are doing like extensive amounts of like protein. So, and a lot of the protein shakes will have like concentrated whey, for example. And so if they're a kid who maybe had a mild milk allergy and they've largely outgrown it, but then they started drinking concentrated versions of whey, they may be more reactive when they're a little bit older. The caseins in cow's milk have quite some identical epitopes to sheep and goat's milk. So as you know, sometimes people are looking for alternatives and those have other nutritional things that are of concern, but in general, most kids are gonna also react to goat's milk, for example, if they're allergic to cow's milk. I'm not gonna talk about this too much because I think I'm gonna be busy here in slides, but basically this is just to say that most kids will tolerate extensively heated milk. So there's been lots of studies that look at this. And the majority of kids will tolerate heated milk. And if they do, if you introduce it into their diet, there's evidence that it helps them outgrow their milk allergy sooner. And so that's something we definitely try to do. Egg allergy is another common allergen. I think something that is maybe confusing is, you know, if you're ever getting lab testing for this, there's the option to do like egg yolk, egg white, whole egg, that sort of thing. My practice and approach is just to, if I'm going to get a blood test, we'll just do whole egg. There are these different components, the ovomucoid and the ovalbumin are kind of the main ones, again, that help us know if a child can tolerate heated versions or not. So the ovomucoid is fairly heat resistant. So if they were to have a high level of that, it may suggest that they may not tolerate a baked egg challenge. There is some cross-reactivity data published between the different bird eggs. In my experience, most kids who have a chicken egg allergy actually can tolerate duck egg okay. And then allergy to chicken meat is actually very rare. So this is just kind of another study to show that basically if you can get extensively heated egg and milk or egg into the diet, basically they have a higher probability of developing egg tolerance over time. So practically speaking, when I'm seeing a new patient for a food allergy of milk or egg, I'm really trying to gauge in my history if they've eaten anything that has baked milk or egg in it. So, you know, for milk products, for example, you know, say they reacted to cottage cheese. Well, I'm asking like, can this child do goldfish crackers, or have they been able to eat muffins or something that you know that has milk baked into it? Because if they have, you want them to keep doing that. And if they haven't, I'm going to offer them a challenge if they're, you know, assuming that their skin test is positive. Same thing with egg. I think it comes up more with egg because people, just because of the texture of scrambled eggs, they're soft. And from an oral motor standpoint, kids can do that. And so with scrambled eggs in their first or second exposure, they'll have kind of hives around their mouth. So I'm asking, you know, have they done, you know, have they been able to do waffles? Can they do, again, like cakes and muffins and banana breads and things like that where there's egg baked into them? French toast is a good one to ask. You know, French toast is fairly similar to scrambled eggs. So if they can tolerate French toast, that's usually a pretty good sign. So those are things historically that are helpful to elicit. And as a pediatrician, if you're seeing this person and they're tolerating baked egg, but they had a reaction to scrambled egg, tell them to keep doing what they're tolerating. They don't need to take the baked egg out of the diet. And you know, the allergist will address kind of what to do with the underheated versions of the egg moving forward. So in terms of the grains, wheat allergy is the most common in children. It's usually outgrown, and obviously not to be confused with celiac disease, which is an immune system reaction. You know, it's often called gluten allergy, but it's not an IgE process. Soy is also another common food allergy, tends to be pretty mild and usually outgrown. My tidbit about soy allergy is that there's a lot of soy lecithin in pretty much every single processed food out there. And generally speaking, children who are soy allergic do just fine with soy lecithin. There's not a lot of protein in that oil. And so for the most part, they don't need to avoid those things. You're going to want to watch out for the more pure forms of soy protein like tofu and that sort of thing. Nuts obviously are a common allergen. Tree nuts are not to be confused with peanuts. They are different. A peanut is in the legume family. So tree nuts are your walnuts, pecans, hazelnuts, almonds, cashews. There is not a skin test for pistachio, but in the world of allergy, cashew and pistachio are identical. So if you have a history of a child having a reaction to something with cashews in it, please tell them to avoid pistachios and vice versa. And there is a fair amount of cross-reactivity between the tree nuts and the peanuts. So if I have a patient who I'm seeing for peanut allergy evaluation, they've never had any tree nuts, I'm going to skin test them for tree nuts as well, because about 25% of peanut allergic kids will also have a tree nut allergy. Other thing is that pine nuts are actually a seed, so they are not in the tree nut family, and coconuts are not a tree nut. So most kids who are tree nut allergic have no issues with coconut. Peanut is obviously one that we're all very familiar with, and it is the leading cause of more severe food allergic reactions, and certainly has caused anaphylaxis and fatal anaphylaxis, unfortunately, in some children. We'll talk a little bit more about peanut allergy kind of in moving forward. And usually peanut allergy is not outgrown. Fish allergy is less common and probably is outgrown as well. The one thing I would point out about this is there's a fair amount of cross-reactivity among the different finfish. There is not cross-reactivity between finfish and shellfish. So those are two separate entities, and you can get fish allergy in young kids. It's the shellfish allergy that tends to present a little bit later than life. The shellfish allergy does also have a lot of cross-reactivity amongst the different crustacea, for example. So if someone's allergic to crab, they should also be avoiding lobster and shrimp. What about the oils? I get asked this a lot, specifically with like peanut oil. Most peanut oils that are used in restaurants are refined. So Chick-fil-A, I think Sioux Falls is getting a Chick-fil-A, I heard. Maybe they already have it. I'm a little envious. But they cook their food in peanut oil, and it's refined peanut oil. And so generally speaking, children who are peanut allergic can tolerate foods that are cooked in peanut oil without having much issues. Now, this gets a little bit tricky because there's other ways of processing oils that are called crude oil. And so those can have some more protein contamination. So, and with other oils that has been identified that people can have IgE binding to the oils if there's protein contamination and therefore react. So it's not, I don't tell my peanut allergic patients to go finding peanut oil foods, but usually they can tolerate it. So we're going to shift our frame a little bit and talk now about diagnosis and management of food allergies. So I'm going to give you another case to think about that. So this is a 13-month-old male. He has dry skin and eczema that started when he was in early infancy. Started out with kind of the typical hydrocortisone 2.5% and typical moisturizers like Aquaphor, and didn't seem to help. Pediatrician added in triamcinolone, still wasn't improving it significantly. He saw dermatology who put him on a higher potency topical steroid like Desinide, recommended they do twice daily baths and wet wraps and lots of moisturization with Aquaphor and Vaseline. Started him on a daily antihistamine in the form of Zyrtec at 2.5 mils in the morning and Benadryl at night as needed. He's still having some flares of his skin, and so he's referred to me as an allergist for food allergy testing. He's been breastfed until he was just over a year of age. Upon introduction of scrambled eggs, when he was about 9 months old, he developed a few hives and his eczema seemed to flare. So they've since avoided eggs. They do limit dairy, but he has had some things with cheese in that, or with milk baked into them, and including cheese, but he does drink soy milk as his primary source. He had peanut butter introduced at home and thankfully had no reaction and continues to eat peanut butter on a semi-regular basis. So this is where, again, I think like anything in medicine, the diagnosis of food allergy is all about the history. I can tell you that, most of the time I can predict what the skin testing is going to show before the skin testing is resulted based on the history, because the testing obviously helps us, and sometimes it's not always clear, but a lot of the times it is. And so it's really important to kind of gauge that timing. Is it those immediate type of reactions? How much of the food did it take to trigger this reaction? What were the signs and symptoms? What did the rash look like? Was it really a hive-like rash? In the era of smartphones, almost all parents take pictures of their kids when these happen. It's helpful to look at those pictures. Was it actually like raised up welts that look like mosquito bites, or was it, more of just a red flat reaction after they had strawberries, more consistent with like a contact or irritant dermatitis? Then obviously for testing, we have skin testing and serum IgE testing as our options, and then an oral food challenge is kind of the gold standard. So skin prick testing, if I were giving this talk in real life, I would probably say, give you the experience and have you know what it feels like so you can explain to your patients what to expect. I think there's a lot of horror stories out there about what allergy testing is really like, and generally it's really well tolerated, including by kids. In my clinic, we use those kind of multi-test devices that you'll see in that top picture. I explain them to kids that they're like little caterpillars, and the caterpillars just get their feet wet and we do a little dance on their back. And this is helpful because we can put multiple allergens all at once, and it tends to go pretty quickly. There's no needles under the skin or anything like that. It tends to be not a very traumatizing experience. The pros of skin prick testing is that there's a really good negative predictive value. So if, if you have a good, we put a positive and a negative control test on. So there's a histamine, which is our positive control, and then basically just salt water is our negative control. If you have good controls, and a skin test is negative, you can really trust that. And as I mentioned, it's well tolerated and you get answers within 15 minutes. The downside of skin prick testing is that patients need to be off their antihistamines for at least a week. So this sometimes can be tricky depending on what time of the year it is. It's very difficult sometimes to interpret skin prick testing on children who are having flared out skin or eczematous skin. Obviously, this requires access to an allergist, which in rural locations is not always the easiest thing to find. And it also, generally speaking, has a fairly poor positive predictive value. So this is where your history is really, really important because there's a risk of over-calling allergy with skin testing. So again, I don't recommend that people test a large panel of foods without a good history to correlate. And if you're seeing patients that you're sending to various places and they're testing them to 50 foods without a real correlative history, I would question if that's a place that you should be sending our patients. People do this in different specialties and that sort of thing, and even some allergists do this, but that is not good practice because you run the risk of having of overcalling allergy. Similarly, there is serum IgE testing. This is formerly known as RAST testing. Again, I will be like, a broken record here. Please do not get large panels of food IgE testing unless you have I recommend you only get specific ones with a good history to correlate. And if you're waiting to get into an allergist or whatever, because what happens inevitably is, a kid who has terrible eczema or is having lots of belly aches, a well-intending pediatrician or family doctor will get with parent prompting, will get a basic food panel. And, like all of us good doctors are really praying for negative results because hopefully, that will, be helpful. But what inevitably happens is that there's positives and it opens this can of worms, and it's really hard to get the worms back in because you're trying to figure out, well, what's clinically relevant for this kid, particularly with eczema and belly pain. Those are really hard. So I would really strongly encourage you not to do that because sometimes the results of those are really difficult to interpret. Another way of, they've looked at this is kind of allergy versus sensitization. So allergy is where there's a positive blood test and they have a clinical history to support that they have allergic reaction. Sensitization is that they just have a positive blood test or a skin prick test. In one cohort of about 1,000 kids in Europe, 12% of that population was sensitized to peanuts. So they either had a positive skin prick test or a positive serum IgE test. When they did peanut challenges to all of those kids, only 2% of those actually reacted based on that challenge. So again, this runs the risk of way overcalling allergy. And sometimes if you just tell them, okay, there's a positive, you avoid that. We now know that early introduction of the foods that kids might be allergic to is actually going to help prevent them of developing, a lifelong food allergy. So we don't want to miss our window of opportunity. And sometimes strict avoidance may actually harm that child and put them at risk for a lifelong food allergy. So again, my key take home here is that sensitization and allergy are not the same thing. And so we need to take that into consideration when we're interpreting the tests. There's also something called component testing, and I do utilize this quite a bit in my practice. This is where we can look at the specific components of of different food proteins to find out what it is that the kid is reacting to. It's particularly helpful with peanut because it can help me risk stratify if I think a child is at higher risk of having a reaction, if we can offer a challenge, that sort of thing. I think this is also an important point. So when you get serum IgE testing, what you'll see in the results is it will give you a number, 0.9 or 1.8 or whatever. And then next to it has a classification system. It will say like class 1 or class 2 allergy. That classification system really means nothing because there's a lot of differences and the probability curves of true allergy are different for different allergens. So for example, A peanut IgE of 3.5 gives you about an 85% risk of actually having a peanut allergy. But the same level in sesame of 3.5 only conveys about a 20% risk of allergy. So again, they're not all created equal. And so that classification system is just confusing and really doesn't actually mean anything clinically. This again is just kind of about interpretation of serum IgE testing. It's really important to be thinking about what is my pretest probability of this person actually having an allergy, and therefore should I test them? So I'll give you 3 scenarios. Patient 1, hives and wheezing after they had scrambled eggs. Patient 2, bad eczema. They eat eggs regularly. The parents never seen them have an acute reaction, but they have bad eczema that's difficult to control. Patient number 3, the kid eats eggs and mom thinks that she gets hyper and misbehaves and wonders if it's a food allergy. If you take serum IgE from all 3 of these patients and they're exactly the same, you get an IgE of 3. What does that mean? So with patient 1, the history sounds very consistent with a food allergy, and you have a positive lab test. This gives you the sense that this is a true food allergy. Patient number 2, you have a moderate pretest probability. Maybe the egg is playing a role in the eczema. And then patient number 3, we don't think that that's a food allergy. It may be some sort of weird intolerance or who knows what it is, but it doesn't sound like an IgE-mediated food allergy. But even though they have a positive blood test, they do not have a food allergy. They just have a sensitization. So I think that hopefully helps you frame kind of what we think about when we're interpreting these serum IgE testing. So food challenges are the gold standard diagnosis of a food allergy. This is what we do a lot in the pediatric allergy clinic. Obviously, these can be a little bit stressful because you're feeding food to a kid that you think that they might be allergic to. Obviously, it needs to be observed by providers, and you need to have emergency medications like epinephrine readily available. I was just doing one this morning to Peanut, so I'll give you this example. I had a little boy come to me who's 5. When he was 2 or 3, he had some skin testing done by an ENT provider and was told that he was allergic to eggs, milk, and peanut. He'd never actually eaten peanut. It had been done in the context of, I think, maybe some rashes or some skin stuff. So he's avoided peanut this whole time. He came to us, we skin tested him. He had a positive reaction, but it was a relatively small positive reaction. And so we went ahead and decided to challenge him. And he just walked out this morning after eating a full bag of peanut butter M&Ms. So I think that's one example. Obviously, we do that in increments, but that's one example where the food challenge can be really helpful. And what I'm looking for as a provider doing this food challenge is we're looking for objective signs of an allergic reaction. We're looking for hives, vomiting, that sort of thing. Sometimes these can be pretty anxiety provoking for the patients because we're telling them to eat a food that they've been strictly instructed to avoid. Otherwise, it might hurt them or even kill them. And so they're very nervous to start eating these foods. So there can be, as you might imagine, some psychosomatic symptoms that can come into play. So in some scenarios, we'll do kind of blinded food challenges, but for the most part, we just kind of do it in incremental amounts and watch and wait and see what happens. I offer food challenges to people if I think that they have at least a 50% chance of passing, because I would rather have a child come in and do a food challenge and react in my care than have them avoid unnecessarily and then have a lifelong food allergy. And also, I think the food challenges can be helpful even if kids react, because parents, number one, see what the reaction is, and it also gives you a sense of when they react. So none of our blood testing or skin testing can tell us how much does it take for this child to react. And a food challenge can say, they got in X amount of doses before they started to have a reaction. And that can be really helpful for parents, especially if they're really worried about minute cross-contamination and small accidental exposures and that sort of thing. So I'm not going to talk a ton about different testing modalities, but I will just say there's a whole lot of wacky stuff that goes on out there and lots of unproven testing. Intradermal testing definitely should not be done. It's pretty dangerous and has a high false positive rate. Patch testing to foods, there was thought to be maybe some role for this in like the eosinophilic GI diseases, but that hasn't really panned out in the research. So generally speaking, this is not something that we employ. There's all sorts of crazy stuff that happens in various alternative medicine professions. There's something called applied kinesiology, where basically like a child will hold a certain type of food in their hands and the provider tries to measure the tension in their muscles to identify if they're allergic to it or something crazy. But you'll be surprised at what parents and families and patients believe with that sort of thing. Similarly, my husband can hardly watch like streaming content with me like Hulu because they always have these commercials for Everly Well and it drives me crazy. But this is one example of a food sensitivity test that's commercially available. And basically what these food sensitivity tests are looking at is IgG. So they get a result like this where it says there's IgG to all these different foods. And, you know, in a certain range, this is a 4+ and really suggests that you have a food sensitivity. There is really no scientific validity behind this type of testing. As we know, IgG is an antibody that our immune system makes, but it's an exposure marker. It's a marker of immune memory. It's not an allergy antibody, and therefore people have positives to almonds and milk, and that's usually because almonds and milk are in their diet. So I obviously do not recommend these and do not put a lot of stock in these. Certainly would not recommend them in pediatric patients. Not going to talk a lot about food intolerance again for time, but the one thing I think that does come up commonly is lactose intolerance. And so the way that I explain this concept to patients is that, you know, lactose, so with cow's milk, for example, as we talked about, we're testing to the caseins in the whey, the proteins in cow's milk, and that's what our allergy testing is able to pick up. But we also know that dairy has lactose in it, and lactose is a sugar. And our body doesn't really make allergy, our body doesn't generally make allergy to sugar, but sometimes people don't have the appropriate enzyme in their gut to break down that sugar or absorb it. That leads to, you know, gas production and bloating and diarrhea and nausea. And so someone could have rip-roaring lactose intolerance, but a milk allergy test, either a blood or a skin test, is going to be negative. And so I think that's a helpful way to kind of explain it to patients that there's some difference, because many, as you know, in the general public, you know, parents, a kid might have lactose intolerance and the parents can say my kid has a milk allergy. And again, a little bit of semantics, but I think kind of helpful to distinguish. So management of food allergy, obviously avoidance is the key, and this often takes extensive education on behalf of the patient and the parent. We recommend that you do a written management plan, like an anaphylaxis action plan. Obviously, epinephrine is the key treatment here. It's going to reverse the reactions the fastest, but antihistamines also play a role, as well as, of course, access to emergency care. These patients need allergy follow-up and kind of a long-term game plan. So in terms of the treatment of anaphylaxis, there's several different flavors of epinephrine auto injectors out there. EpiPen is probably the most well-known name and has been around the longest. There's also Auvi-Q, which is kind of in the lower right corner. There's several other generic versions and Adrenaclick. Thankfully, EpiPens are not as expensive as they used to be. I think there was a time when they were running between $300 and $600, which is crazy. Thankfully, they're usually more affordable now, particularly with insurance. So usually patients can get them for less than $100. There are two different doses. There's the regular EpiPen, which is 0.3 milligram dosage. I use this for my patients when they're above 25 kilos or above 50 pounds. And then there's the junior, which is the 0.5 milligrams. They come in a twin pack because rarely people will need to use a second dose if they're having a severe reaction. So I do not recommend that people break apart the twin pack, that they keep them together as much as possible. In terms of an anaphylaxis action plan, you know, different EMRs have kind of different ways that these look. The one that is up on the screen was just pulled from the FAIR website. A lot of times schools will use something that looks a lot like this. Basically, it just walks someone through if their child is having a reaction or that student is having a reaction, what do we do? So if it's mild symptoms, a few urticaria around the mouth, maybe a little bit of nausea, maybe one episode of vomiting, you could start with antihistamine. But if it's hives plus anything, as we know, you know, if there's any symptoms, the lung, heart, throat, skin, gut, etc., you're going to using the epinephrine because that's going to reverse the reaction the fastest. We know that delayed administration of epinephrine is a risk factor for death related to anaphylaxis. Obviously, if epinephrine is needed to be administered, then we recommend that patients go on to get either urgent care or emergent care evaluation for kind of ongoing monitor to make sure they don't need repeated doses or have any signs of a delayed reaction. You also will see that if a child goes to an urgent care and emergency room for anaphylaxis, they're often going to be treated with a course of corticosteroids anywhere from 1 to 3 days. There is not a lot of data to support that practice, but I think we commonly see that done still. The other thing is, in terms of the education, I definitely, if you can get it in your pediatric practice, if you can get an EpiPen trainer device, I highly recommend having one in your clinic so you can show your parents and your patients how to use them. They're kind of intimidating things. And so I think it makes a big difference to kind of let them handle it, put it onto them. So the trainers obviously don't have a needle, and so it allows them to kind of feel the pressure it takes to get it to activate and that sort of thing. And I think this goes a long way. So when someone's actually having a reaction, they're not like trying to read the label and figure out what the heck to do. If they just have some comfort, they have exposure, some muscle memory, I think that's helpful. There's also billing codes for epinephrine training that you can do if you want. So challenges of avoidance, basically tiny amounts of the food protein can cause reactions. Again, there's a lot of education that needs to happen. I think I would say that a lot of times many of the reactions happen when children are in the care of their very loving and well-intentioned grandparents, because maybe they're not thinking of it, or they're at a baseball field and someone feeds their kid a snack. And I think people or parents who live with children without food allergies, it often doesn't even cross our mind that foods can be dangerous to kids. And so, this is, a big burden for families and children living with food allergy, that they really have to kind of become their own advocate. And there's a high rate of accidental exposures, particularly in peanut allergy, when they've looked at this. And then in kids who have lots of different food allergies, obviously can impact their nutrition, if they are allergic to multiple foods. This is probably one of a bigger pet peeve of mine. I think advisory warnings are incredibly confusing to patients and to me and to everyone. Basically, food labeling with a variety of different language. There's nothing that's standardized, but food companies have to say or put out a warning if there's a potential for any contamination. And so I think to protect themselves, most of them will say, may contain or process in a facility that has this. What is the actual risk to the patient is really hard to say. I think it's pretty low, but not impossible. So usually when parents ask about this, I kind of have just a shared decision-making conversation saying, like, we don't know that for sure. It says may contain, but more likely it may not contain. And so, some parents choose to avoid very strictly. Some parents say, well, we do that and it's been going okay, especially if they can't have peanuts, but they can have tree nuts, that sort of thing. So not a lot of data there, but it's a tricky thing to navigate as a provider. So what is the future of food allergy management? So immunotherapy, I think, is the present and is the future of food allergy. So just touch on it kind of briefly. Basically, there are several different allergen-specific approaches under investigation for the treatment of food allergy. As I was, looking up kind of what's going on, what's studied, there's even like some sort of like rectal injection immunotherapy that's being studied in mice. So stay tuned. There's all sorts of exciting things happening. But the big three that I think are out there that have the most likely potential to emerge for clinical use is oral immunotherapy, sublingual immunotherapy or SLIT, and epicutaneous immunotherapy or patches. Oral immunotherapy has a little bit of conflicting evidence on safety and efficacy. I would say that up until recently, most academic centers of allergists were not doing oral immunotherapy, but other places around the country have. And I think there is an FDA approved product for this, so I'll talk about that briefly. But again, the biggest concern, I think, is safety. And then the clinical trials do show that it tends to desensitize kids, but it doesn't necessarily cure them. So what that means is, they're able to tolerate a certain amount, and that protects them from severe reactions to accidental exposures. But rarely are these kids able to go on and eat the culprit food kind of ad lib. SLIT therapy is drops. This, I think, has some promising potential with maybe less side effects, but still being able to desensitize to a good amount. This is not in clinical practice. So there are some places not too far from you across the border in Wisconsin that does some of this. And generally speaking, I would just be wary of that sort of thing. And then the patches, I think, are exciting because this seems a little bit less invasive in terms of the family day-to-day dynamic, where basically you apply a patch to the skin, the child gets desensitized to the peanut through the patch on their skin. The patch is moved around from week to week, and this protects them to probably a lower level of peanut, but it certainly has a significantly better safety profile. And so this was in phase 3 clinical trials and showed pretty good efficacy, but logistically the patches were not staying on well. So they're back to the bench, I guess, kind of trying to figure out a patch that will stay on busy active kids who sweat and swim and bathe and all that good stuff. So Palforzia is our one FDA approved oral immunotherapy product that we have. It was recently approved in 2020, and it is a peanut powder, and it's approved for ages 4 to 17, currently in clinical trials for ages 1 to 3. Basically, this is where a child is given what they're allergic to in the form of peanut powder if they're peanut allergic. So how it works is this is done in an allergist office. There's an initial escalation day. And then if they tolerate that, they go home and they start taking doses of this product at home every single day. And every 2 weeks, they're coming into the clinic for a doubling of that dose. The updosing phase takes about 6 months. And then at the top dose, which is called maintenance, they would be getting 300 milligrams of peanut protein, which is about the equivalent of 1 peanut kernel. They would continue that indefinitely. I think a lot of places who implement this will eventually transition the children over into just like 1 peanut or peanut butter, a peanut M&M or something like that. Generally speaking, this has showed quite a bit of efficacy in the ability to desensitize. So 77% of the kids in the study were able to tolerate the 300 milligram dose, and many of those actually tolerated even more. However, there's a high risk of reactions, both systemic reactions, about 14% of them required doses of epinephrine. And usually those are at the updosing visits, but sometimes were needed at home. And there's a relatively high dropout rate in the studies because of adverse events. So this is definitely not for every family. It's a very expensive, time-intensive process. But if there are certain families who are living with food allergy and want to talk to it about it, this is an option that you can refer to an allergist for. Okay, so I'm running a little bit tight on time, but I do want to get into this last little case and we'll wrap up. So this is a very cute 4-month-old, if I do say so myself, who likes to visit me in the middle of the night. She's even cute then. She's born at term and she's exclusively breastfed. She's meeting her developmental milestones appropriately. But at her 4-month-old child check, mom wants to know, how do I start introducing solids? She has a niece, the mom has a niece who has a severe peanut allergy, so it makes her nervous, but she definitely doesn't want her kid to have a peanut allergy. So how do you guide this person? So in the past, as pediatricians, we used to say, we think you need to avoid peanut during pregnancy and during breastfeeding. And we don't want you to eat any of the highly allergenic foods until, dairy until they're 1, egg until they're 2, nuts and fish, et cetera, until they're 3 years of age. Also, if there's high risk or atopic dermatitis, maybe using a hypoallergenic formula will be helpful. Fast forward to 2008, when the AAP Committee on Nutrition met again, we kind of realized that maybe that it was actually harmful and that delaying the introduction of allergenic foods was actually creating more food allergy. And so they kind of changed their tune a little bit and looked at the data and said, you know what, there's not enough data to say that maternal avoidance during pregnancy or breastfeeding are warranted. You should introduce solid foods around 4 to 6 months of age. And we do not recommend that you delay introduction of allergenic foods, but there wasn't really any clear specific guidance on how to introduce allergenic foods. Enter 2015 when there was the LEAP study. This was kind of a sentinel study in the world of food allergy, because what it showed us is that basically early introduction of peanut in kids who are at high risk for developing peanut allergy actually led to a reduced risk of them having it later on. So what is a high risk for peanut allergy? A kid who had moderate to severe eczema and or had an egg allergy. And so again, they would test these patients. They would they kind of randomize them into eating peanut versus avoiding. And the kids who ate peanuts, despite having a positive test, had a significantly lower risk of having peanut allergy at 5 years of age. So that caused our AAP committee to change the recommendations, and now they do support early introduction of infant safe forms of peanut to reduce the risk for peanut allergies. We don't really have a lot of clear guidance in that document on introduction of eggs, and early introduction to other foods has not really been super reproducible. It is with eggs, but milk and wheat and soy and sesame and that sort of thing, we haven't been able to kind of reproduce that model of early introduction being protective. And then obviously we no longer support partially or extensively hydrolyzed formulas to prevent atopic disease, even in patients with a family history or atopic dermatitis, et cetera. So when should you use an allergist to help guide food introductions? If you have a patient who has moderate to severe eczema, despite a good skincare regimen, good topical steroids, or of course they have a history of maybe having a reaction to a food, they should go to an allergist. If you have a child who has a positive IgE test that was obtained for whatever reason, but they have never eaten it, that is a good person to go see an allergist. Again, routine screening is not recommended without a clear history. And then certainly if they're siblings, that can be helpful. This is just a little guide from the UpToDate, a flow chart of kind of how to help you walk through this. So does the infant have any following? Do they have a confirmed reaction to an IgE food? Do they have bad eczema? If so, can you get access to an allergist? If so, send them there. If not, you can get serum IgE testing. If it's negative, they can introduce at home. If they don't have eczema, if they don't have any signs of having a reaction thus far, and they don't have a strong family history, you can have them introduced at home. If they do have some mild eczema and a family history, you can still suggest it at home, but if they're not comfortable, then you can refer them on to an allergist. So just really brief case wrap-ups. For the first case, I was gonna ask if anyone knows what the food reaction was caused by. I'll give you like 15 seconds. So I will just go ahead.
Fish.
Sorry, I didn't hear that.
I said my guess would be the fish.
Yeah, so if you recall, the reaction happened around 3 o'clock and the child was eating celery, carrots, and hummus. And it was actually a sesame. It can be ground up into a paste called tahini that is a frequent ingredient in hummus. And even though the child had had hummus before, sometimes this was maybe a different kind of hummus, that sort of thing. And so you see kids react to hummus, you want to be thinking about a sesame allergy. And he, in fact, did have a sesame allergy based on his skin testing. Hummus can also contain pine nuts, so that's something to think about. Sesame is kind of an emerging food allergen, and so there is increased labeling laws for that, which is helpful for families. We obviously told him to strictly avoid, have an anaphylaxis action plan and an EpiPen, and we'll repeat testing in 1 year. And then, oops, sorry. Okay, the second case was the child with eczema. What did we do for that child? So we did skin prick testing to environmentals, perennial allergens, so the things that are indoors, because obviously that can play a role in eczema. The child did have positives to cat and dog, which he was exposed to in daycare. He did have a positive reaction to egg. So they had been I recommend they go avoiding egg, but he hadn't had baked eggs. So I scheduled him for a baked egg challenge. He had a small positive to milk. I recommend they continued eating the baked milk and work towards lesser heated versions of milk. I give patients specific instruction on how to do that. And then we did not skin prick test the nut, the peanut, because he'd already eaten that, but the soy and the wheat were negative, and obviously need to continue their skincare management plan. And then the case 3 of that really cute 4-month-old, this child is by history a low risk for food allergy. She does not have eczema, no immediate family members with food allergy. Just recommend that child would introduce kind of normal foods with cereals, veggies, fruit purees, etc. When their oral motor skills are ready, you can start introducing peanut butter or peanut powder. I do recommend a decent dose when you do this. So not just like a little, maybe the first time or the second time you can give a small amount and watch them to 10 to 15 minutes. But I've had patients where parents will just give them like little licks of peanut butter, like off of their spoon or something like that, 4 or 5 times. And they're like, okay, we're good, we're in the clear. And then boom, on the 6th one, when they have a larger dose of peanut, they have a reaction. And so those smaller doses may actually be sensitizing. So I recommend that when you introduce a decent amount. So kind of a goal of 1 to 2 teaspoons of peanut butter, which seems like a lot, but kind of mixed into mashed up bananas or puree or whatever. And ideally do this, 1 to 3 times per week. And then obviously introducing egg and dairy products based on appropriate oral motor skills. And you may consider doing this in the baked form first. So that's the case wrap up, and with 2 minutes to spare. So sorry I'm not leaving much time for questions, but I'm happy to take them if anyone has any.
I'm listening to see if anyone comes up with anything. Thank you, Haley. That was very good. I see one comment, and I don't know what the doctor is talking about, but he goes, he sees some patients go to a clinic in Wisconsin that does SLIT, slit after
Yep.
IgG testing. What is that about?
So, so this is kind of what I was alluding to, and being a little bit cautious about where you're sending your patients, because in my experience, that clinic that shall not be named overcalls allergy very significantly. And so almost every patient that goes is told that they're allergic to XYZ, and they get put on these very expensive cash pay drops that are going to fix that food allergy. And the reality is, based on history, most of those people do not actually have true food allergies. So I, don't I try to take the high road and not throw anyone under the bus, but I would be very wary of that sort of thing.
Okay. Question I have is, was with your skin pinpricks and use the solution or dab on there, do you make your own, or are these standardized solutions? And is it standardized throughout the country?
Good question. These are commercially standardized or extracts that we purchase. There's like 3 or 4 companies, ALK, Hollister Steer, kind of big companies that produce this extract that you purchase. So yes, it does tend to be standardized. You can do some like fresh fruit testing, for example, but that is not well standardized. So can certainly increase your risk of having false positives.
And my final question is, okay, you have someone with a specific food allergy. Parents are demanding, when can I reintroduce? What's your standard answer as a general pediatrician?
It's really variable. It's nuanced. So it's hard to give kind of a clear cut, this is what you can do. With the milk and the egg, you can kind of work them through like progressively lesser heated versions. So, if a child can do goldfish crackers, then say, okay, well, maybe try, doing, a cheese cooked onto a pizza baked onto a pizza for 25 minutes and see how they do, and kind of give some guidance to see if the child can tolerate lesser heated versions of the milk. Same with the egg, kind of like I mentioned, like, okay, for a while, we're going to do cakes and muffins. If they're doing okay, then we can start introducing like egg that's not been baked or cooked for as long, like brownies and cookies and egg noodles and lasagna or meatloaf, things like that. You kind of work your way down to where you may say, okay, we're going to do, like I said, French toast. That if they can work their way towards French toast, that's a pretty good sign that they're really close to fully outgrowing their egg allergy. So that's kind of with that, with peanut and things like that. I don't generally recommend that they would reintroduce at home because that could be very risky. And so I recommend doing that under the care of an allergist.
Great. Well, it's 2 minutes past the hour. And so I want to say thank you very much for tackling a complicated subject and in an entertaining way too. So thank you
Good,
very
good.
much.
Yeah, no problem. Have a great day.
You too.